um, alveolus you mentioned clinically.
Yes, sir.
What were those features that suggested it to be involving the alveolus?
There was spontaneous uprooting of the teeth, and on inspection there was ulceration. The growth was extending over the area where there was tooth loss, and on palpation there was induration, and the mandibular was around the mandible there was thickening and growth of the tumor.
All right, there are more questions. Actually, when you are examining for the cranial nerves, what do you have in mind? Why are you doing examination of 9th, 10th, 12th cranial nerves? Does it change your stage?
Yes, sir. The internal jugular vein superiorly has the 9, 10, 11 origin from the jugular foramen. If there is involvement of the nerves, that indicates there is skull base involvement. So there is substaging of the disease.
And in the AGCC 8th edition, this has got a greater significance. Which other nerves are important? These are the cranial nerves. Any other nerves or other cranial nerves which are important now?
Lingual nerve involvement showing referred pain to the ear. Then,
Trigeminal nerve, any significance?
sir.
Trigeminal nerve.
It is the mandibular, from the mandibular branch of trigeminal nerve, lingual nerve comes, and it
See,
irritates the
actually,
auricle.
the whole idea is that perineural spread can take it to the skull base. So
Yes,
it's
sir.
important to examine for all that. They change the
Yes,
stage, and
yes, sir.
there is also the length of nerve that is involved, which makes it T4B, because based on that they interpret whether it will be going up to the skull base or not.
Yes, sir.
About the inferior alveolar nerve, some friends have written in the chat box. That is more for the mandible being involved or not. Then that segment of mandible is to go alongside.
Yes, sir.
Anyway, I'll ask you more questions. I'll allow others to first ask you. Dr. Saha, please. You're muted, Dr. Saha. Dr. Saha, you're muted.
You said ENT examination is normal. How far you have been able to examine clinically to comment that ENT examination is normal?
Sir, indirect laryngoscopy can be done as an OPD procedure to assess
What you have
the.
done? You said ENT examination is normal. So what are the other areas you've examined? Because if you have a oral lesion, you should
Yes, sir.
examine other important sites.
Yes, sir. Due to field cancerization, there can be chances of involvement of the larynx and the oropharynx and the esophagus. So we need to do an indirect laryngoscopy as an OPD procedure for assessment of the larynx. And ear
Soumya,
was.
did you understand his question? That is what is
Yes,
important.
yes, sir. I examined for
You
even
see,
for
in a surgery examination, you are not having a indirect laryngoscopy in your hand.
yes, sir.
Okay,
Right.
that is the examination you will send the patient to a
Understand,
surgeon.
yeah, you're right. Understand the question first. He may not be asking what you are trying to answer. Indirect laryngoscopy is an office procedure which is done nowadays as a routine, but it's not available during your examination. So
Okay,
during examination, when you're saying clinically ENT examination is normal, you examine the oral cavity. What did you look for? What else do you look for? That's what he's asking. So answer the question that is asked, right?
oral
What you can
cavity.
see without a laryngoscope, you can see the retromodular area.
Yes, sir.
You can see the tonsillar fossa. You
Yes,
can
sir.
see the part of oropharynx.
Yes,
So
sir.
that is the thing you can see without a mirror examination.
So
Yes,
you
sir.
Because
mentioned,
routinely you are not doing a mirror examination.
you mentioned about RMT, and you should have described more. That is what he's saying about the pharynx, the oropharynx. That examination is a part of it. Then you can examine the external ear, you can examine the nose. That's a routine. But
Yes,
the
sir.
whole idea of ENT examination is to rule out any other primary,
Yes.
right?
Yes,
Now,
sir.
why are you looking for field cancerization more in this case than you would do in any other patient?
Because there is a long duration keeping of the kidney over the mouth. There is by the saliva, it can be the entire oral cavity is
I'll make it
can.
easier for you so that other students also gain for their answering in the exam. how does it differ between HPV related? Because now AJCC has divided them into HPV related and non-HPV related cancers, right? So
Yes,
how
sir.
is it different between HPV related and non-HPV related cancers? What are the differences? Quickly.
HPV related cancers are mostly on the posterior part of the oropharynx, around the tonsils and the
Then
posterior pillars, and it is more having a better prognosis than non-HPV
that
related
depends on the
malignancies.
subsite. That is subjective. Okay, next.
The field cancerization is more in the non-HPV related malignancies.
That's correct. And
Then
node positivity is more with HPV cancers, although
yes, yes.
the depth is more with tobacco-induced cancers. What else? What age group is commonly affected? Younger patients for the HPV
HPVs,
cancers, older patients for the
non-HPV
non-HPV
related cancers.
cancers. What else? Of course, high-risk
Mm,
behavior. You'll have the sexual habits that will come through. And the sites, as you correctly mentioned, would be
yes.
usually the oropharynx, the posterior part. Anything else that is different?
Mm,
Remember now the prognosis of cancers in the oral cavity and head and neck is dependent on the site also, and that goes to subsite.
yes, sir.
Subsites also become important. Therefore, when you're describing the examination of oral cavity, it becomes necessary. I'm very happy the way you described the dental examination because
Yes,
it
sir.
makes sense. And at the same time, you probably in the picture you missed out the submucous fibrosis, which was glaring.
Yes, sir.
You also had nicotine stains which are visible on the entire mucosa, which should be described because they really make your presentation even better. The leukoplakic, melanoplakic patches, all of them.
Mm,
And you know,
yes, sir.
submucous fibrosis is also linked to the genetic predisposition. You must understand that. Because not
Yes, sir.
everybody becomes, I mean, with cigarette smoking becomes a cancer patient. There are many other factors which come in, or tobacco chewing becomes a cancer patient. Any role of marijuana smoking? It's just the
Um,
tobacco or marijuana also contributes.
Mariano, there is, I don't know, sir.
It also causes release of those toxins. It also has nitrosamines of a different range, and it also causes lots of biochemical changes. We have limited time here, so we can't be discussing it, but I'll take it up in some webinar later on. Now, Dr. Ratna, quickly, and then Dr. Sai, and we'll come to the management.
Yeah. So, was there any widening of the mandible? You showed us the lesion which was extending over the gingivolabial sulcus on
Yes,
the mandible.
there was a thickening of the mandible around the lesion where it was grew over
You
the
mentioned
nose.
about induration. You can talk about if the mucosa was mobile over the mandible or not, and if there was any widening of the mandible, because that will give you an idea about mandibular involvement clinically. So,
Right. Dr. Sahai? All right.
Okay,
Yes.
sir.
Dr.
You said,
Dr. Saha and Dr. Sahai, the names get little.
yeah, yeah.
You can always
You
ask
said,
that. Sahai,
in
anything to say? Just 1 minute. Just once. If he's Dr. Ramanuj has been able to join now. Dr. Ramanuj, any questions so far?
No, sir.
Thank you. Dr. Saha, you were saying something. Now you can speak.
yeah, you say in HSCC 8, as you said, the TNM classification, T is apart from size. What else is taken into account?
We will come to
For
that. Saha, we'll come to that. I'm sorry. We'll come
okay,
to
okay,
that. Anything in the examination so far, we'll come to
okay.
diagnosis.
No, it's
Anything
okay.
in the exam, you're okay?
No, it's done. It's done. Fine.
Yeah. And mouth opening, how much did you mention, Somit?
3.5, he said.
3.5 centimeters.
Between where do you measure it?
Between the interincisor distance, sir.
And how do you measure the tongue protrusion? How is it calculated?
Uh, tongue protrusion, if the tongue protrusion for any
Somit,
deviation
if you
of the
don't know, say you don't know. Don't waste
Mhm.
everybody's time. Your smile says it all. Don't try to be naughty here. See, it's from the frenulum attachment and further. You measure 1.5 centimeter to 2 centimeter at least. Right? You're getting my point.
Yes.
And if you look at it, that's where the oral tongue has projection. And where is the oral tongue stop? I mean, confined? Where does the pharyngeal tongue start?
And the foramen of where the posterior 1/3 and the anterior 2/3 joins the foramen cecum.
Very good. Is there any difference between the two? If you get a cancer there versus cancer in the front?
The prognosis is poor as the posterior skull base involvement is more in posterior region, and there is more morbidity due to difficult drooling of saliva and saliva.
Treatment-wise?
It is difficult due to T4B. It can go due to the posterior pterygoid involvement and
it behaves
skull
like
base
oropharynx only, dear. So it will be surgically rarely possible to get a margin, and they'll mostly be treated by chemo radiation, and they tend to have nodes lower down in the neck. And now coming to the question that Dr. Saha was asking you, because it is important here, when you mention the stage, this is your clinical stage. Can you tell us what is this concept of clinical stage? I mean, you should have put a prefix. What prefix you would put?
C T4A.
Small or large? C.
Clinical stage.
Small c or large c?
Small c, small c.
Okay, large means capital, I'm sorry.
Yes.
And what is small r?
That is a recurrent disease.
What is large R? That is capital R. Residual disease. What is Y?
Y is post-treatment.
Post chemo or radiation. And if you're putting R and capital R or others, the Y would come before. It's important. That's about it. Let's move to the, now what is it that you would like to have more before you stage it as T4?
Sir, what did you
say? The AJCC 8th edition, that's what Dr. Saha was asking you.
Yeah, depth of invasion was also included.
Okay.
Yes, sir.
Why have they, can you tell us why have they included the depth of invasion?
Because the margins has to be three-dimensional.
Sorry, question is different. You answer what you want to answer. Your what I'm asking you is a very simple question. Why have they made depth of invasion a part of the T staging?
Because
no, your answer is no. Don't wait. Don't waste time. Earlier we used to call it tumor thickness. Now we are very precise, and it starts from the basement membrane down. You measure it. Actually, it's a pathological measurement, right? Yes. And depth of invasion is directly related to the involvement of the lymphatics and therefore the lymph nodes. And involvement of lymph nodes is directly related to the prognosis. In fact, involvement of lymph nodes is also now been replaced by extranodal extension. Clear? So depth of invasion, that's your answer to the question which I asked. I'll provide you quick answers at the same time. Okay. Now, based on depth of invasion, sorry.
Hello.
Dr.
Comment on this.
Dr. Ramanuj, you are speaking?
Yeah. Right, sir.
Dr. Ramanuj, yeah.
Sumit, see this, just one comment. It is better to write an M0 rather than an MX, because if you see the AJCC 8th, AJCC 8th has done away with the term called MX. So
no longer
you have basically proved it that there is a metastasis, right? M1. If not, right, C M0, that's enough.
Perfect point. And actually, the reason for that, Sumit, is that clinically you're saying no metastasis, no? So you're not at fault. And MX has been removed, as very rightly brought out by Dr. Ramanuj. So don't use that term. A lot of other students can also correct it in their presentations. Now, can you tell us quickly through, I mean, before you call it a stage, I think there'll be some question relating to examination. That is why I'm holding it there. Dr. Saha is done. Dr. Ratna, you asked your questions of examination.
I just wanted to see his image once again because we want to know the extent of involvement of skin over the chin. You've not shown us the outside image, no?
We show the outside image.
Is there some mobility between the mucosal lesion and the skin, or is it fixed to the skin?
It is mobile, ma'am. It is not fixed to the skin.
So you said there was induration around it. You've not told us anything about the base of the ulcer. You said it's a gray looking ulcer. I think there needs to be some improvement in the description of examination findings, because gray looking ulcer should not be spoken. You should tell us about the size, site of ulcer, what are the margins like, what is the edge like, and what is the floor, what is forming the base, all that, and if there is mobility over the skin or not. And then you talked about mucocutaneous junction of the skin. I think we should be able to talk about the fact whether the vermilion border is involved or not. And what about the white fold of the lip? The parts of lip you should be able to describe. We should have been able to say that the lesion seems to be extending beyond the midline to the opposite side also. Right? So all these things should be highlighted, I feel. They should be highlighted because they will have an impact on management.
Good. And also the point about skin involvement, which is very rightly brought out. Could you move it, and was the induration going beyond the lesion? And I can't see the ulcer in your picture, but I can see some
Clarity.
uh, so maybe here some bit is there, although you can use your cursor to show us, and the lesion is here. And what about the place where he used to put his quid? That place is
It was
completely
in the
healthy.
gingival, right side gingival sulcus. Yes.
Was that completely healthy? No problem there.
It is involved.
Unusual, no? So, and the submucous fibrosis at the angles is clearly visible.
Yes.
Now, what would happen if the skin was involved?
Then you need to anyway. This requires that almost more than 1/3 of the lip has to be removed in this patient. So we need
No,
to
no,
do
my question
reconstruct.
is about the stage, actually, what we do
Stage
later on.
doesn't change. So,
No, doesn't change means suppose the mandible was not involved and the skin was involved.
the size of the tumor increases, depth of invasion will increase. So the stage may
See,
change.
what exactly do you mean by T4A?
T4A means involvement of mandible, floor of mouth, um, and at nearby adjacent resectable structures.
That is T4B, unresectable. Resectable, A,
Resectable.
resectable. So what about skin?
Skin, it will become T4A.
So these are things you should read, and I would not spend a lot of time there because individually to take a case would be a little bit of a challenge. Now, lip tends to do better than the other lesions. Lip and gingival sulcus, they do better, and unlike tongue and other lesions. Now you can come to the stage where we had reached the examination parts. We'll have more oral cases to be discussed, so we'll quickly go on. Now we have 5 minutes to finish this. So what about the? In fact, we overrun. Now let's move to the. Can we move on, Dr. Shah, for the examination? Further?
Yeah,
Yeah.
yes,
Okay.
yes.
Yeah.
I think go for some part of management, some discussion.
Yes. Let's move on. What would you do now to manage it?
I would like to do investigations to confirm the disease, support and stage my diagnosis, and treat the patient. Investigations to confirm the disease, I would like to confirm the disease with an incisional biopsy of the lesion from the anterior edge, and to assess the depth of invasion. I can use a CCT of the head and neck. CT of the head and neck.
Somebody has got a disturbance going. Yes.
CT of the head and neck, and for metastatic workup, I would like to do a CT chest, and CT head and neck, and um, we need to based on that we can assess the based on CT we can assess the mandibular involvement or present or not, how much, and based on I would like to have a multidisciplinary team meeting and decide further treatment of the patient, whether it is a neoadjuvant radiotherapy or
No treatment. We didn't ask you. Well, stop. Just had a workup. Don't finish your script.
and I would like to
Just keep quiet. That's over. You've already done enough damage. So we will come to the individuals. Like you confirm your diagnosis. You said I'll do what biopsy?
incisional biopsy, wedge
Tissue
biopsy,
biopsy. Where will you do it from?
the anterior edge, sir.
Okay. Now I won't ask you why because we've been doing it for ages now. We've been talking about it. Now number two, there are a lot of questions people ask you in the exam about edge biopsy, wedge biopsy, and scrape cytology. Now, can you tell us something about it? What is edge biopsy? What is wedge biopsy?
Edge biopsy is the biopsy taken from the proliferating edge of the ulcer and not
Putting the normal
involving
skin,
neck.
normal adjacent tissue. Next, what is wedge biopsy?
With the normal tissue and
What
not
is wedge? Wedge is over. Wedge now.
edge is the from the anterior. It is a I don't know the difference between.
There you are. And actually, it doesn't matter to me, but some examiners do ask, and it happened with me in one examination. They say that you make a W cut with normal tissue as well as the abnormal tissue. The whole idea is it's an incisional biopsy. There are all types: punch biopsy, edge biopsy, wedge biopsy. I'll leave it to the other faculty to also chip in. And the idea is that you get the most proliferating edge and some bit of normal tissue for not for comparison anymore. There are few changes that are not visible. You can actually see dysplasia in the surrounding tissue, which may be missed out. So it's better to provide some normal tissue in addition. Okay. So dysplasia is because usually in tobacco chewers there is more lesion than you think. Therefore, induration becomes very important, right? And you just ran through your imaging. We would not disturb that part. Biopsy part is done. Then the second thing you said was to stage it. You'll do the imaging. Now, what did you say in the imaging? Because you could quickly hear that you did CT, head and neck, and
CT head and neck, ultrasound neck, and CT thorax for metastatic workup.
Why do you do CT thorax? Do you do routinely in all oral cancers?
No, sir. It is only it is very less common that oral cancers metastasize. If it is metastasizing, mostly it is to the lungs.
But you said so, no? You said CT thorax as a
Yes,
routine. Is it recommended? It's not
It
recommended.
is not routinely recommended by.
When do you
NCCN.
actually do it?
When there is any
Patient is
high
symptomatic. One is patient is symptomatic, right? And next,
And this patient is what? You say stage 4A, locally advanced disease
yes, sir.
with mandibular invasion,
Yes, sir.
right?
with lymph node plus.
Yes, sir.
So
So
do you think the justification for
There is
doing the metastatic workup. So it's
Metastatic.
symptomatic patient, right? Depth of
sir.
invasion being more than 15, which is 1.5 centimeter, correct?
Yes, sir.
Third is extranodal extension, which
Yes.
also indicates PET scan. A lot of people like to do PET scan for distant metastasis.
Yes.
And lower lymph node involvement, level 4. That's
four.
where you would like to get a CT thorax. A lot of people feel in tongue cancer, especially since there are skip metastasis to the level 4. So level 4 can indicate towards the lower involvement, but not as a routine. It's not for early cancers. You don't do that. So locally advanced, as you understood, recurrent disease, third, extranodal extension, and those with a level 4 involvement.
Yes.
Okay. Now,
Yes, sir.
so that's about the CT. Dr. Shah, any questions here? Then Dr. Ratna.
no, it's
Any
okay.
role,
Dr. Ratna.
any role of MRI?
MRI helps to delineate the soft tissue invasion. In tongue cancers, you can use MRI.
And
In this
tongue,
patient,
tongue and finish the list.
tongue and buccal mucosal cancers,
No, buccal, because I don't need to bother. Floor of the mouth.
floor of mouth.
And also for nerves.
Marrow.
Nerves
No.
you're looking. And how about the orthopentagram, OPG? Any role?
Yes, orthopentagram helps us to assess the mandibular involvement, but neck nodes cannot be assessed with OPG.
And now with the current OPG, which is digital, and you can go in circle, you can get a much better assessment of the reconstruction that you need to do for the mandible. Then you can get with CT. It's important to understand that. Right. So, Dr. Ramanuj, any questions so far here, or we can move? How do you manage this patient now? We have to wind up because the next case is also there. We have a, there was an issue with the previous link. We've got a quick link again, so that we'll pause after this case so that you can log in through that link, and then everybody would be smooth. So some were not able to join, so we got 2 more links to make it comfortable. Yes, please carry on.
Sir, I would like to do a wide local excision with 1 centimeter margin all around the tumor and with adequate reconstruction based on the defect. Using PMMC or flap, and lip reconstruction can be done with any baseline flap for the tumor defect being more than 1/3 of the lip.
This is your case. Can you do Evans slender in this? You cannot do. So don't give me answers which are not related to this case. Evans slender is done for smaller lesions, right? For T1, maximum T2, right?
Yes.
This is T4A disease. How would you put Evans slender here?
What about mandible?
And that
Mandibular
What about mandible?
Yes, sir. We need to do vascularized
What about nose?
bone along with the PMMC. You can take a rib along with it, or vascularized flap can be used for mandibular reconstruction, and the scapular spine can also be used. When can be used.
So, if I can sum it up for you, your answer would be a composite resection,
Yes.
Yeah.
three-dimensional clearance
Yes.
with a margin of at least 5 millimeters. But clinical, when you're doing surgery, gross margin is 1 to 1.5 centimeter. When you read this in your books, please don't get confused. 5 millimeter is impossible to measure
Yes.
when you're doing a gross resection, right? But it should be three-dimensional, and composite means along with the mandibular segment, and that will be segmental mandibulectomy. And in this case, it is anterior segment. So it will need reconstruction, as very rightly brought out by Professor Shah. You will use synthetic, or you can do free fibula or radial artery forearm flap, but you need bone, so free fibular is better. You correct about that. Or you can use, if you don't have the facility, then you can do PMMC with rib, or you can do the synthetic plate reconstruction. And then what you have removed, you have to replace. You have removed the skin, you have removed the mucosa, you have removed the muscle. So you can say osteomyocutaneous flap.
Yes.
Okay, so that will take care of it. Followed along with the neck you did not mention. What?
Neck we need to do in the right side level 1 to level 5 MRND, and since there is involvement on the opposite side, I can do a prophylactic supraoverhead dissection on the left side also.
It is called, not prophylactic term is gone. It's more of a elective term. Elective. And another reason, Dr. Ratna asked you a very, very good question at that point and your description. Why should you do the contralateral side here?
Midline is crossed by the.
That's why she was asking you to describe it properly, because you are able to communicate that I'm aware of it. Okay. And what would you do for the reconstruction?
Reconstruction by the for inner lining, I will use PMMC flap. Outer we can use delta pectoral flap based on the PMMC from the pectoral branches of the thoracoacromial vessels, and delta pectoral from the perforators of the internal mammary.
So PMMC DP, or you are using talking free flap, then you can get, don't have to move the PMMC, then you can have both sides covered. And these days there is a bi-pedaled PMMC where you can use just PMMC to provide inner cover as well as outer cover. So you need inner lining, which is with skin. Outer line cover is also with skin. But you're fine in saying PMMC followed along with DP. And in the same breath, finish it with adjuvant radiation. Okay, so that you completed your answer.
Yes.
Right. We have three more cases. Dr. Shah, any question here in addition?
No, it's okay. It's okay.
Dr. Ratna?
Yeah, he should be able to clarify the management of mandible in terms of whether there is only cortical involvement or marrow involvement also. Because then the extent of mandibulectomy and reconstruction would vary. And if periosteum is involved, then maybe nothing needs to be done in terms of mandibulectomy.
And if you were comparing the imaging, MRI shows you involvement of marrow better than the cortex. So MRI has a role there also. Involvement of marrow would mean you can't do marginal mandibulectomy. Involvement of the cortex alone would mean you can do marginal mandibulectomy. What are the other criteria for marginal mandibulectomy and contraindications?
Any nerve involvement, perineural spread can.
One next. That's one.
Then any abutment of the mandible only alone we can go.
How much? How much? So you should be faster than that, dear. How much table is to be there minimum before you?
Minimum 1 centimeter of the.
So you should say that. That's more important, right? Yes. After you've got the margin. And one thing is, as rightly brought out, if the marrow is involved, there is no possibility. Cortex alone, you can do it. And then ideally, usually when you got the resection done, if you place the specimen on the bone, it shouldn't topple over. That means you've taken out adequate margin, right? Your margin should be good. That's a broad thing. Inferior alveolar nerve involvement would mean segment has to go. and edentulous patients, elderly, you will not be able to do marginal mandibulectomy because it will crack. Okay. And gross involvement is a contraindication. Abutment is not a contraindication. Okay.
Yes, sir.
Now, Dr. Sahai and Dr. Ramanuj, last comments and then we close.
Sir, hello. Sir, I
Yeah,
think that
now
was a
we can
good
hear
case
you.
presentation.
Earlier also.
Hello.
We could, yeah, we can hear you now.
No. Hello. Right. Sir, I think that it was a good case presentation.
Thank you.
What are just two queries to add to this one? After you have done all the surgeries, what are the roles of radiotherapy in this patient?
He has mentioned that. We've covered that, Ramanuj.
Then, sir,
Yeah. And since he has asked, can you finish it for the next candidate also, so that since I'll still, value the question that Dr. Raman is going to ask you. Now, Sumit, you can finish that. What are the modes of radiotherapy in this patient that are available? We didn't discuss that. Yeah.
External beam radiotherapy is preferred, and there is high risk for osteoradionecrosis of the mandible post radiotherapy.
Sumit, I'll
Since
make it
there is
faster. One is external beam radiotherapy, brachytherapy. Advantages, disadvantages?
brachytherapy in the oral region due to the it's less preferred than external beam radiotherapy.
Why?
Because the needles has to be placed for long duration in the
That's
mouth.
all right. That's not a problem. It is good for organ preservation. It's good for preventing collateral damage and comorbidities, but it's a disadvantage that it won't cover the neck. Okay, so when you have neck to be covered also, then brachytherapy may not be ideal. So that ensure and read the dosages. Whenever in doubt, say 50 to 60 grays and then boost. So it depends. We'll have it in the next case. With that, I think we can conclude it. You have made a good presentation, Somit, for the first case. Now I'll request all the faculty to kindly bear with us. There was a technical glitch with the previous link. So we've got another link fresh. So we'll, after this case is over, we'll quickly log in with the new link which has been provided in your in the WhatsApp group, and we will, Sukriti, we can now pause here and go for the next presentation after the new link, with the new link. Kindly rejoin, all of you, please. I request you. Thank you so much.